You're 8 months into your first pregnancy. You feel like your baby is in distress. You've started to bleed heavily. You're rushed into hospital. You find yourself lying in a trolley, in pain, confused, in the midst of a chaotic ward when a doctor rushes over to tell you, Mama, tunataka kufanya operation ya cesarean section. Kama iko delay ya kudeliver baby na uko na bleed, baby aweza kupata oxygen mingi, anaweza kuzaliwa kama akili si mzuri sana, ama anaweza kufa na life yako iko kwa risk. Tunataka kufanya hii operation haraka ya kusave wewe na mtoto yako. How did that make you feel? Hold on to that feeling, because that is what so many patients experience anytime they attempt to access healthcare services. My name is Dr. Yasmin Mulji. I'm an obstetrician and gynecologist. My multicultural heritage has made me recognize that language has been my primary way of communicating and expressing myself anywhere I've been. I believe that being able to have and use your voice is fundamental for anyone to successfully integrate into any society. I hope this talk today will inspire us to rethink how we choose to address the language barrier in our everyday practice. The language you just heard me speak was Swahili, a language I grew up with, having been born and raised in Uganda and Kenya. Any Swahili speakers in the house? You'll understand what I was talking about earlier on. And to the rest of you, perhaps you felt confused or uneasy? Although this may be an uncomfortable conversation to have, it is an important one for any multicultural society to engage in. So what the doctor said earlier on, but in English, was this. Miss, we need to do an operation called a cesarean section. If there is a delay in delivering your baby and you continue to bleed, the baby could have reduced oxygen supply to the brain, could be born with learning disabilities, and could even die. And your life could be at risk as well. We need to do this operation urgently, as soon as possible, in order to save yours and your baby's life. The Irish playwright George Bernard Shaw said that the single biggest problem in communication is the illusion that it has taken place. We've all been there, been in situations where we've struggled to get our point across, even when we're speaking the same language. We know how frustrating and uneasy it can make us feel. Now consider what it feels like when you don't share the same linguistic proficiency as the people that you're trying to communicate with. You're in a restaurant in France on a hot summer's day. Summoning the remnants of your school-learned French from the depths of your memory, you confidently ask the waiter for a drink, un boisson. And to your dismay, the waiter returns 10 minutes later with a fish, un poisson. Frustrating, maybe a little bit funny, but certainly not the end of the world. Now consider this degree of miscommunication when lives are at risk. Emergency medical decisions are being made every day without patients being fully aware of what's going on and what their choices are. The results of this can be life-changing and even life-threatening. So, how do we, as healthcare professionals, provide a quality service to our patients if we can't even engage with them in conversation? And who should the onus fall on to ensure that clinicians and patients understand each other? Us or the patients themselves? So what are the implications of not getting this right? The scary thing is we don't actually know. The data simply doesn't exist. But here's what we can infer. In 2011, the Office of National Statistics revealed that people who do not speak English proficiently are 3 times more likely to not be in good health compared to those who did. The health status for women in this subgroup was even worse compared to men. In the UK, Asian women are 2 times more likely to die in pregnancy compared to white women, and Black women are 4 times more likely to die in pregnancy compared to white women. There are numerous reports that recognize different ethnicities as being a barrier to care, but language is rarely mentioned as the causative factor in order to establish a direct correlation with clinical outcomes. Worse still, most clinical research still has no English as a rejection criteria, further highlighting the major gap in knowledge we have in our ever-growing non-English speaking population. Put plainly, this means that if you don't speak English, your experiences may not even count in the data, which forms the evidence base of research that is then used to make clinical decisions for everyone. This is the status quo today. But if we look further ahead, international migration will account for up to 75% of the UK's population growth over the next 25 years. Our National Health Service needs to consider how it serves a society that is increasingly cosmopolitan, and all that comes with it, including greater linguistic diversity. More broadly, do we, as healthcare professionals, have a role to play in encouraging patients that speaking the local language will be beneficial for their physical, mental, and social well-being? The way that I address the barrier of language in clinical settings changed after I met a young woman who had emigrated from South Asia. Let's call her Mariam. I met Mariam 6 months after the birth of her baby via cesarean section. And it was only then that she was able to disclose to me that she had been suffering with domestic violence. Something that had been missed by other healthcare professionals throughout her pregnancy and in the 6 months after she gave birth. Currently in the NHS, we use translators to communicate across different services and languages, often with no additional time given. A non-English speaking patient may get the same 20 minutes of my time that an English speaking patient gets, despite requiring interpretation for a 3-way conversation. The effects of this are twofold. As a clinician, it is difficult to ascertain if your patient has been relayed the right information and if they even understand what you're trying to tell them. And as a patient, it is difficult to build the space, time, and trust in order to disclose any sensitive information or uncertainties about healthcare queries. Mariam was the last patient to be seen on my afternoon clinic list. She was referred with non-specific symptoms which didn't really add up. An advantage was that she had a member of her community acting as a translator in whom she could trust. The removal of time pressure from my side allowed me to ask exploring and probing questions, and this, in combination with her feeling like she was in a safe space, led her to disclose the domestic abuse she was facing. Despite Mariam having repeated access to services throughout and after her pregnancy, it was clear that once in the room, she didn't really have a voice. The translators often used with her were the perpetrators of the abuse, her own family. Many obvious signs, such as bruises and missing teeth, went unobserved and unreported. Mariam's life and the well-being of her child was imperiled, partly because she could not express herself to receive the support she needed. So what changed for me after I met Mariam? I learned to put aside my discomfort about mentioning to patients the importance of learning and speaking English. Language barriers can cost lives. We're in the business for saving and improving lives, and therefore we need to break the stigma around encouraging non-English speaking patients to access resources to learn English. It's part of our duty of care. So, how do we get comfortable talking about this? A simple way is to signpost help. Being aware of resources such as local support groups, community classes, AI technology tools, and relaying them to patients is as important for their long-term outcomes. This is possible. I've tried it before. The most recent example being a Polish woman. Let's call her Irina. I met Irina and her husband at the beginning of their pregnancy, at a time when Irina could not speak basic English. Through a telephone interpreter, I mentioned the importance of learning and speaking English, not just to help her through her pregnancy, but more generally in life. I even demonstrated the use of a language learning app on her phone. Now, the encouragement and support given to speak English at hospital visits, prolonged hospital stays, as well as her own incentive to learn really paid off. By the time Irina gave birth, she could effectively communicate with me in English and expressed her gratitude. Irina now has a voice that can be heard and understood. She'll be able to speak on behalf of her voiceless newborn. She'll be able to speak to the teachers about her child's progress at school. She'll be able to navigate everyday tasks such as banking and shopping, and even have more options in the workforce, potentially being able to provide a better quality of life for herself and her family. Healthcare has evolved from paternalistic to patient-centered. We now need to take it one step further by transforming patient-centered care to person-centered care. So next time you encounter a patient, a person who struggles to communicate in English, what will you do to ensure that you can communicate with them effectively at that time? And what will you do to encourage them to take that first step towards learning English? I want you to acknowledge the role that you play in supporting patients whose lack of local language proficiency makes them more vulnerable than others. The actions that you take in that moment will not only positively impact their treatment, it can provide a route out of difficult situations for them and nudge them towards the greater and longer health and social benefits that speaking a nation's language can provide. Asante sana, thank you.